So this is my department. We have a very great team which work together with all the faculties, the helping professors, the guiding professors, and nothing can be done without the great efforts and the help from my postgraduate students who help us in maintaining the records and treating the cases and doing everything that has been needed as per the smile train guidelines that has been given. I'm very proud to announce that we are associated with the smile train, and the grants for the treatment we receive them. We are receiving them from 2007. So we are associated with the Smile Train since 2007, along with the Department of Oral Surgery and Plastic Surgery at Ajay Vinoba Rural Hospital at the Tamaki Institute of the Medical Sciences, deemed to be university. So whenever it comes to the management of the cleft, it is not a single person or a single unit or a single department, but it is always a team approach which comprises of so many departments. So it is a multidisciplinary rather than an interdisciplinary approach for the treatment of the cleft lip and palate. The treatment protocol for the cleft lip and palate that we follow at our institute is the first and the foremost important is the pediatric evaluation. Now, why this is important? We know that the fetal growth at the cleft appears at the almost at fifth and sixth week of the intrauterine life, and this is where the heart also develops, and that is the reason why most of the cleft lip and palate infants are associated with the heart anomalies. Therefore pediatric evaluation majorly for the heart anomalies and for the syndromes associated should always be evaluated. The next comes the pre-surgical nasal molding appliance or the therapy that need to be given in the infants, followed by the lip repair and the palate repair at an appropriate age as advised by the surgeons according to their advice. Then there is a follow-up for the evaluation of the growth, so that the growth of the maxilla and the mandible should be appropriate accordingly. It should be there. And also a very careful watch on the caries. We'll be discussing this session on how the caries need to be evaluated. And then at the age of 7 to 8 years, there is a need of expansion. So why there is a need of expansion? Because we have to undergo the fistula closure and the alveolar bone grafting, followed by the orthodontic procedures with or without the orthognathic surgeries, and last comes the revision and the rhinoplasties. So whenever the patient comes to us immediately after the birth, or for the PNM appliance in the infancy, we always tell them that it is not just an association with us for just 2 months or till the lip and the palate has been repaired, but it is an association till the adulthood, till 20 to 25 years of age. So parents and the patients later on need to be known to this fact that they have to be associated with the orthodontic team, the surgery team, and the complete cleft care team till their age of 20 to 25 years. And not only that, but there are also subsequent and the long-term evaluations also, which includes the audiological assessments, the otolaryngological assessments, the assessments for the OSAs, language and the speech assessments. Later on, the family genetic counseling for their future plannings, dental evaluations, interventions at the child as the teeth begins to develop, and moreover, the psychological counseling not only for the parents but also for the child. So, the management of the cleft lip and palate is broadly and grossly divided into 4 stages. Stage 1 is from birth to the 2 years of the age. Stage 2 is from 2 to 6 years of age. Stage 3 is from 6 to 12 years of the age, which is considered as to be the longest treatment phase for the cleft lip and palate. And stage 4 is where the treatment is done for the permanent dentition along with the surgical correction. So the management of the cleft lip and palate, it extends from from birth to 2 years almost. And what is important in this is the objective of treating in this age is to get a good weight so that the child gains good immunity, so that the child can be operated for the lip repair and subsequently with the palatal repairs. So what comes in help is the fabrications of the feeding plate in the passive obturators, and then we need to strap the premaxilla because it is jetting out, and therefore we need to align them so that there is a good alignment of the premaxilla with the other lateral segments, and of course which comes under the domain of the infant orthopedic procedures. So the treatment of the patient with the cleft lip and palate, it has always been a subject of controversy, because where there are advances in the plastic surgery, they have corrected many deformities in the cleft lip and palate without the pre-surgical infant orthopedics. And therefore, there is always controversy why there is a need of the pre-surgical infant orthopedics when the surgery alone can take care of everything. But everything has pros and cons, the advantages and the disadvantages. There are wider cleft, extensive clefts. There is more nasolabial deformities, and therefore they pose a surgical challenge for the surgeons, where the approximation of the soft tissues actually become very, very difficult. And therefore, even if it is an incomplete cleft or there is an absence of cleft lip and palate, there can also be seen a nasal deformity which cannot be corrected by the surgery alone, but therefore needs an assistance for the pre-surgical orthopedics. So, as compared to the unilateral, it is very much important to concentrate and think about the problems associated with the bilateral, because they are more as compared to that of the unilateral, because we have a protruding and elevated projected premaxilla. We have an underdeveloped columella. You can see in the image which is placed above the premaxilla. So that is an undeveloped philtrum of the upper lip. The prolabium is actually attached with the nose. So the prolabium, the upper lip and the nose are one part actually. There is a distorted lateral labial segments. We have narrow positions and impaired growth potential for the segments. Therefore, bilateral needs a phasing. We cannot study everything at one go like unilaterals. So the initial stage we need to align the premaxilla. Then the nasal cartilage need to be pushed, they need to be molded, and then the elongation of the columella followed by alignment. So like this. So the parents, suppose, why should I treat my parents? Why should I treat the child so early? So there is a need for intervention. There is a proper relationship of the involved structure, and that need to be achieved during the active growth of the normal phase of the craniofacial development. We know there are the high levels of the hyaluronic acid and the maternal estrogen, and that maternal estrogen is there in the baby's body only till 2 to 3 months of the age, and that is the time where we actually need to mold the cartilages so that proper molding and the alignment of the nasal cartilage can be achieved, because after that age the maternal estrogen level decreases and the hyaluronic acid also cannot maintain the elasticity of the fibrous tissue and makes the nasal cartilage plastic, and which cannot be further molded. Therefore, it is a very crucial age that it should be started. Therefore, there is a need of early. So, this is the great man who started with the pre-surgical nasal molding after Matthew, who stated in his study that the ear cartilage can be molded. So, based on the philosophy of Matthew, Dr. Barry Grayson thought that why not to mold the nasal cartilage with a pre-surgical nasal molding in the cases with the cleft lip and palate, so that before the rhinoplasties, the nose can be corrected and they can be molded to a normal anatomy. So we have already discussed that why PNAM, because as the infant grows older, the tongue usually adapts to the larger defects and therefore it becomes then very difficult for them to adapt. Early interventions also provide a lot of tissues, the more because we are molding the tissues, right? So there is an expansion of the tissues, a lot of the tissues available for the surgeons even to get a good amount of the repair, and the scar formation is therefore very less. So there are the certain objectives of the bilateral cleft lip and palate to be treated with the PNAM. We need to centralize the premaxilla in the middle. Then we also need a non-surgical elongation of the deviated columella, improving the nasal projection, approximation of the lip segment, reducing the width of the nasal tip and the nasal alar bases, and therefore reducing the width of the alveolar segment, so that with only small amount of the expansion of the arches, the alignment of the arches later at the age of say 14 to 15 years when we do the normal orthodontics, it should be minimal. So when we were talking about the pediatric evaluation, the importance of the pediatric evaluation, it is majorly done for the heart anomalies, the amount of the defect, the presence of the Simonard band. The Simonard band is a tissue band which includes the muscles of the facial tissues, and therefore may interfere with the PNAM procedure, and with the permission and the advice of the surgeon, if needed, this Simonard band need to be cut off because it may interfere with the nasal molding. Then presence of any natal teeth, if present, then they need to be extracted. And the weight of the baby, because we need to continuously monitor the increment in the weight of the baby, and other craniofacial abnormalities evaluated. So in the literature, there are various methods given to take the impressions of the infants, like upside down, prone positions, and every position has their advantages and disadvantages associated. But we at the department of at SPDC, we find it very easy to take it just standing behind the infant with the head being supported with the hand, and asking the patient to, like, the infant should be allowed to cry, so that we are assured that the airway is maintained and impression can be taken. So the materials that need to be used are the elastomeric material, the heavy body material. There is no need of the wash impressions because this is a passive appliance. So a heavy body material can be used, and I will advise to restrict the use of the green stick, impression compounds, and the alginate, because breakages are there with the alginate, and also the heat of the green stick and the impression compound may not be bearable to the tissues of. So this is how an ideal impression should look like, where there should be incorporation of all the tissues that is needed, that is the alveolar segments, the premaxilla, the vomer and extensions, the depth of the vomer, everything. So this is a pretty good quality of impression. This is further followed by the lab procedures, where the defect is being closed and we form a uniform arch with the wax adaptation, and then the appliance has been fabricated. So before fabrication of the appliance, the wax framework is done for with appropriate thickness of the wax for For the appliance, acrylic appliance, which should be 2 to 2.5 millimeter. And you can see above the appliance, there are the retentive buttons fabricated in the wax. And then they will be heat cured to get the retentive buttons, which will be attached to the appliance. So this is how the flasking has been done. Then we get a heat cure acrylic plate. Later on, these buttons are attached at the center of the defect. I'll show how it has been done. So once the appliance is ready, finished and polished, just place it inside the mouth and now mark exactly the middle of the defect, and that point is the position the button should be placed, which is approximately 40 to 45 degrees in angulation to the maxillary plane, projecting outwards. After the retentive button has been placed, then comes the molding of the plate. How the alveolar ridges will be molded? So it will be molded with the application of the soft liner and removal of the acrylic for creating the space, so that after the soft liner is moving the premaxilla and the alveolar segment, so we should have some space for them to shift. So removal of the acrylic and application of the soft liner. This is how the biomechanics of the alveolar segment works for closure of the defects and alignment of the alveolar segments. So after this, the appliance is worn by the infant, and as there are no teeth, we know we need some retention for the appliance to be there fixed into the mouth, and what comes to help is the retentive tapes and the elastic bands. So this is how the appliance is worn with intraorally. So we can see the two retentive buttons, and the two retentive buttons, the appliance is fixed intraorally with the help of the chick elastics, and above them you can see the retentive tapes with the elastics holding the appliance in the mouth. Now for the prolabium lengthening, we need to have the vertical lip taping. So the vertical lip taping from the prolabium to the appliance, it helps in stretching of the prolabium for its lengthening. And after the patient is comfortable with the wearing of the appliance, then comes the role of the nasal stents to be added to the appliance, so that we can start with the nasal molding. So this is how the defect was there initially, and this is at the end of 2 months, where you can see there is a bit rolling of the premaxilla backward and reduction in the defect of the alveolar defect of the maxilla in the bilateral case. So after the defect has been reduced, as I said, that there is now the time to start with the nasal molding. So this is how it is prepared. A swan shaped wire is bent, and then acrylic button is attached to it, which has two lobes, upper and the lower lobe. Now why these lobes are there? Because the depression in between the two lobes, the kidney shaped lobe, is prepared so that the nasal alar rim rests into that depression of the upper and the lower lobe. So this is how it is fabricated. For unilateral it is 1, for bilateral it is 2, and then we attach both the retentive, both the nasal stents, the acrylic buttons with the prolabium band. Now what is the role of a prolabium band? The prolabium band will help to deepen the nasolabial angle. So I'll try to explain from this diagram how does the appliance works in the bilateral cases. So as the baby wears the appliance, the plate is passive. So every time it is falling off from the palate cases. So this is how the depth is being created. You can see the highlighted circle. So initially, when the tip of the nose was attached to the prolabium, you can see where the circle has been highlighted. There is a good amount of the nasolabial, subnasal base of the nose, right? So we got a good amount of the subnasal base of the nose. So this is how initially it was. You can see the prolabium, which is directly attached to the tip of the nose. But now in the second image, we have a lip separate and the tip of the nose projected separately. So they are not joined anymore. So this is what we can achieve with the prolabium. Yes, there are some theories and literatures where they say that the PNAM have effects on the vomus and the premaxilla, and we do agree with it because retracting a premaxilla will definitely lead to restraining effect on the maxilla, and as we know that the vomer cannot be bent or the premaxilla cannot be we cannot get the premaxilla behind easily. It cannot get back. There must be some bone bending, right? So there is definitely a bone bending, and we call it as a vomerine nasal septal bending. So there are many articles which states that PNAM, the pre-surgical nasal molding in bilateral cases leads to the vomer bending and the premaxillary rotation downwards, which later on lead to the development of the skeletal class 2 cases in the bilateral patients. But we cannot ignore the advantages associated with the cases. So I would like to show one of the long-term follow-up of my bilateral case. He is Master Amman Warkar, and these are the latest photograph that I have. And recently I got a call from his mother at 2020 May. He underwent a minor surgery for with a distraction osteogenesis. So Leaford was not needed for him, right? Neither bi-jaw surgeries were needed for him to set the maxilla and the mandible according to the cranial basis. But just a small procedure of the Leaford distraction, the distraction osteogenesis was done, and the face was corrected. The class 1 skeletally class 1 acceptable face was corrected recently in May 2022. So this was all about the bilateral. We will quickly go through the unilateral cleft lip and palate cases which treated with the PNAM as a procedure. All remain same, but there is a anatomical variation and the morphological difference. In the unilateral, we can see there is no facial symmetry like it was in bilateral, okay, because there was a projecting premaxilla in the middle, but at least the left and the right face in the bilateral were symmetrical. There is no facial symmetry in unilateral cleft lip and palate cases, and that is the reason why the nose is always deviated to the non-cleft side. And this is the major goal that need to be achieved, that is facial symmetry. Again, the appliance is fabricated, it has been placed, retentive button positioned, and this is how the defect is been closed. Just please concentrate on the image. This is how the defect is closed, and this is how the defect is finally closed with just 1 millimeter. So these are the pre and the post photograph of the alveolar molding, and once the alveolar molding was done, then okay, these are the results of the alveolar molding where such a thumb size defect was reduced to 0. So after the defect was reduced, then the nasal molding was started with a single retentive nasal swan, the retentive button and the stent, and this is how we achieved the result. The defect was close to almost approximation of alveolar segments. So again, Grayson has selectively molded the appliance, and this is how the biomechanics of the Grayson's technique it works, just like the bilateral that we had discussed. So we know that the plate is passive, it moves and it activates the nasal stent to mold the nasal cartilage. Kindly appreciate the results that we have achieved pre-surgically post-PNAM. You can see how the flattened nasal tissue has been very well molded. So we have a good amount of molding of the nasal cartilage along with the approximation of the lip tissues. So these are the post-surgical photographs. You can see a very well maintained and a developed cupid, and I should really congratulate my surgical team led by respected Dr. Bhola sir and Dr. Borle sir, who was the project director when the Smile Train was started. The Smile Train, we were very fortunate enough to have Borle sir as the project director for the Smile Train, and now it is Dr. Bhola sir who is the project director for the Smile Train, and his team along with Dr. Anand Zadav and Dr. Bhushan Mundara, and many of his colleagues are really doing a very great job. We also are fortunate enough to have Dr. Abhilasha Yadav with us, who had initially operated many of my cleft infants, and I'm very thankful to Madam for giving us such beautiful results for my cleft lip and palate babies. So you can see how beautifully the facial symmetry is achieved. This is the second case. So we have a very good nasal molding with nasal symmetry and the facial symmetry, a good lip length, a very nice cupid of the upper lip, and a good facial symmetry. So these are the advantages of the PNAM and the benefits, that we have a very good repositioning of the alveolar segment. The process also improves the infant's ability to feed and generate the suckling forces. And the nostril heights and the width ratio and the height of the alar group significantly improved post treatment also. And we have long-term studies who stated that the nasal corrections done with the PNAM was sustained even after 15 to 20 years. So this is the beauty of the PNAM. Following the guidelines of the Millards, this is how we follow it, with the rule of 10 at the age of 10 weeks with a pound of 10 weight and hemoglobin 10 mg. The baby is ready for the surgical treatment to join the cleft edges, to lengthen the soft palate, and also to repair the palate and muscle. This was the stage 1 of the cleft management. Now coming to the most important and the most neglected segment of the treatment modality for the cleft lip and palate, which extends from 2 to 6 years. Now why I say that it is a most neglected one? Because after the palate has been repaired, what we tell patients, that in orthodontist special, that you need to come at 7 to 8 years of age, that there will be implantation stage, and we need to expand the arches. And therefore patient also get relaxed, that they even don't bother to see a dentist caries or any other malfunctions or malformation or anything else, because their doctor, their dentist, their orthodontist, their surgeon had advised them that they do visit them at 7 years of age. That's the role of a general dentist practitioners and a pedodontist. And therefore, this being, even though in textbooks it is written that no active treatment is needed during the stage, no active treatment needed during the stage, but continuous monitoring of nutrition is very much important in the stage, and therefore should be always and observation in these 4 years. Primary are very important. They help in speaking, they maintain the space for the eruption of the permanent teeth, they shape the face, they prevent the early childhood caries, they keep the future dental cost minimum, because if the total tooth material is there, why there is need of any processes or any surgical treatment then? And also reduce the risk of the, because why it is important, because abnormality of the tooth eruption and the number we see in patients, early childhood caries, the tooth decays, the developing malocclusions, and so many things can be seen in the deciduous dentition, which is mostly and many of the time is ignored by the parents, because parents mostly focus on the surgical treatment modalities of the patient till the patient looks good after the surgical repair of the lip, and the patient can eat and swallow after the palatal repair. Then their eyes open at the age of 8 to 9 years when they see a small amount of the crossbite and crowding appearing in the mixed dentition stage, and then they visit their dentist or an orthodontist. But this middle period of the development of the jaws, the development of the tooth is lost, and here we need to be very, what we say, we need to be very particular about taking care of patients. And what we need to see is the development of the early childhood caries, because the ECC can lead to loss of the total tooth material and thereby again reducing the arch size of the tooth, of the upper and the lower jaws, and thus developing a malocclusion. We know that anyways there will be a malocclusion with the cleft lip and palate cases because of the constricted maxilla, because of the fibrous tissue. Why we need to add up it? By allowing the dental caries to happen, and this is where we need to be aware of, because if this has been lost, what is developed is a dental caries, and these dental caries need to be taken care with respect to the diet, the biofilms been developed, the caries, the time taken for the patient to take care, and the tooth surface, how it need to be cleaned, is very important for the patient to maintain. One should also take care about the abnormality of the tooth eruptions and the tooth number. They should be according to the age. And what is important is to have a look and care on the biofilm, the soft white plaque on the tooth. Even though it is very common in kids, in adults as well, but it is mostly ignored by everyone. But it should not be ignored in the cases with the cleft patients, because these biofilms are susceptible to lead to the development of the caries. Now these dental caries, they appears and they destroy the enamel surface, which is actually very important, because many of time the deciduous teeth are present. There may be a permanent or congenital missing of the permanent teeth, and therefore what comes to help is the deciduous dentition, and therefore the deciduous dentition and its maintenance and care is very much important. It becomes important for us to take care. The intrinsic discoloration is mostly caused by the dental fluorosis, the amelogenesis imperfecta, the tetracycline stains, and the pulp necrosis, and they need to be taken care of in the early management. Along with those stains, there are some other lesions and the spots, which are again important to be taken care of in the second phase of that management, which are the white spots of the hypomineralization and the brown spots, which are because of some dietary habits like tea, coffee, berries, iron, or they might be some intrinsic stain as well. So evaluation of the white spot and the brown spots become important. If the care is not being taken, then what it may lead to severe and the gross amount of the gingivitis and the periodontal diseases. And these gingivitis and the periodontal diseases with bleeding and not a good quality of the bone can again lead to further complications in the mixed dentition and the permanent dentition stage, especially when the cases there is a need of surgical interventions. Fluoride application may help to reduce the tooth decay, and also it is recommended to use the fluorides, but the concentration of the fluoride should be maintained, because excessive fluoride used can lead to the the pigmentations on the teeth, leading to fluorosis of the enamel. So care should be even taken while using the fluorides. We should always encourage the parents to advise their pediatricians, or we should consult the pediatrician to prescribe the sugar-free medications wherever it is possible. Also, the behavioral habits should be changed. For example, if the child is while sleeping is having milk, make it a habit to have water and then sleep. Prevent some of the habits like thumb sucking and tongue thrusting. Can be, if they are there, then they should be prevented. There is a new philosophy which has been raised, which is known as the lip philosophy. So it is very important to make the parents aware about, just ask them to once lift the lip and have a look. Even the general practitioners should follow this philosophy of lift the lip. It should be done at every visit the patient is coming to the dentist. for the toddlers, for the preschool children, for the adults, everyone. It will give you the insight and the current situations and the scenario of that particular condition and that particular child. So this is what this philosophy is. What is, there is a major role of the diet in the dental caries, and therefore a healthy diet is always advised. Choosing a toothbrush is very important for a child because still we have parents whose kids have all the 20 deciduous teeth and have not yet started with the brushing because they are afraid of hurting the tissues. Being a cleft segment, being a cleft area, they feel that it might hurt the tissue. They feel that it might lead to some disturbance in the palatal repair being done. But after certain age of the after certain time, the palatal repair, the palatal tissue is not going to be hampered. So therefore, choose a small head brush with soft bristle, easy gripping, and with a right size of the toothpaste. You need to brush the teeth. It is mandatory as soon as the first tooth erupts. So this is how it is important even to take care of the second stage of the management of the orthodontics as well. Though not a part of orthodontics, but a very major part of the comprehensive cleft care for the parents and kids. So we have some posters available. I can share with you all where the oral cleft for the comprehensive cleft care for all the ages has been very well depicted in those posters. I would also like to share that I'm working with the Smile Train, which is associated with the FDI and the GSK Pharmaceuticals. So we have come up with MUOCs, the MOOC, that is a massive open online courses. We will be inaugurating them and launching them in the last week of the September. In the last week of the September, the MUOCs will be launched. So we have two MUOCs. One is for the general practitioner who wish to be a part of the team of the FDI and the Smile Train to help us in the comprehensive cleft care. And one MUOC is purely for the orthodontists who are working for the comprehensive cleft care. So the MUOC link will be launched in the World Congress conference, which is in the last week of the September. It will be on the online mode. It seems in the Mumbai is hosting it. So this is my FDI team and my Smile Train team who are working together for the comprehensive cleft care. And as soon as the links are released, I'll be happy to share with you all. So you can just register yourself for the links and you can grasp as much as the knowledge regarding the comprehensive cleft care for the betterment of the cleft child. Thank you so much. I would like to share that we have departmental cleft activities. So we had certificate courses in the cleft orthodontics, which was under the guidance of our respected the Smile Train project director, Dr. R.M. Borle sir, who is also the vice chancellor of the university. Our HOD, Dr. R.H. Kamre sir, Dr. Sunita Srivastava madam. We had external faculty, Dr. Punit Batra, and the HOD of the plastic surgery department from the AVBRH, Dr. Suhas Jaju sir. Uh, Dr. Priyanka Niranjane is the HOD Department of Curriculum from SHPR, an orthodontist and a reader in our department. We have Dr. Nitin Bhola. Dr. Nitin Bhola, HOD Department of Oral Surgery, SPDC, and Dr. Abhilasha Yadav. So this was our team who conducted the certificate courses for 2 years in 2012 and 2013. We had the 6 PGs as members and the candidates for the certificate course, and also external candidates from all over the India also joined the certificate course. So it was a good collaborative activity, and we still have the certificate. Monthly, there are MDT clinic, that is a multidisciplinary treatment clinics, which is performed every month, where the Cleft team discusses formulating a treatment plan for the Cleft cases, and also the progress of already the cases which have been treated is been discussed in this MDT clinic along with the records and the current status. So this is a good collaborative activity for the for assessing and evaluating the progress of the Cleft care. The fellowship program is run under the umbrella of the School of Advanced Studies as fellowship programs in cleft orthodontics and surgical orthodontics, which is a full-time 1 year curriculum course. And we have all the internal candidates. Also, we have external candidates registered for this fellowship program as well. So, these fellowship programs are since 2012 in the university. So, when we come talk about the treatment protocol, for the stage 3 and stage 4 of the orthodontic treatment for the cleft lip and palate cases, the highlighted box of 8 to 9 years is a very crucial stage where the treatment, maximum amount of the treatment is done in this age, where the expansion is the key factor for the treatment, where we need to prepare the arch. We have to prepare the arch so that the surgeon can work, so that the arch can be aligned and the orthodontic can complete maximum of the orthodontic in this tenure of the age of the patient. Because orthodontics and orthognathic surgery will be followed after the treatment protocols and the treatment strategies which is planned for this particular age. So as I said, that stage 3, it is the longest treatment protocol, and really takes a long time, and almost you can see here that how much time it is extending from 6 to 12 years of the age, and most of the active treatment is carried out in this age, which is arch expansion, maxillary protraction, and few simple procedures with the orthodontic treatment where the cases may not need any surgical orthodontics. So such cases are done in this period of the time, that is the stage 3 of the treatment modality. We all know that the maxilla of the cleft is a constricted jaw. Why? Because there is a repair in the lip, there is repair in the palate. The repair in the lip and the palate leads to a fibrous tissue development. Fibrous tissue does not have elastic tissues. So it does not allow the maxilla to grow in neither the anteroposterior dimension, neither transverse, nor in the vertical dimension. And that is the reason what happens is the maxilla remains constricted and hypoplastic because the growth is not allowed. Even when we are thinking about expanding the maxilla, the respect should be given to the amount, the quality, and the quantity of the fibrous tissue available in the maxilla or in the palatal tissue should be assessed and evaluated before planning for any expansion therapy. So that is the reason why we see crossbites in the cleft lip and palate cases because of the constricted and where the maxilla is not permitted to grow. So various appliances are available where the expansion can be carried out. In deciduous dentition and the early mixed dentitions, these are few of the good appliances with Z spring and the W arches which can be used for expansions. Then we have the quad helix, the bihelix, expansion screws, and very well workable and a very good appliance to be used for the not only for the cleft but even for the other constrict arches of the maxilla is the NITA expander. The NITA expander is a very good appliance because the nickel titanium has its shape memory potential, the property of the nickel titanium, and that is how it is working. So proper selection of the NITA expander plays a very important role. Dr. Priyanka Niranjani will be giving us a demonstration of how to select a perfect NITA expander for any particular case. So this is one of the most crucial appliance that is available for the expansion of the maxillary. After the expansion, now why there is a need of expansion, it is very important to understand, because uh, what is needed, the two parts of the maxilla need to be combined as one. The three parts of the maxilla in bilateral need to be combined as one, and that can be done with only alveolar bone grafting. So when we want to do an alveolar bone grafting, it should have a particular space so that the bone can be put into it. We should take care that the procedure should not relapse, the procedure should not fail, because it is a very difficult time that the patient undergoes when this surgery has been done. We are taking the bone from the iliac crest, sometimes from the elbow, sometimes from the ribs, sometimes from the cranial base. Depends that from where we need to take the bone for the harvest. And very difficult for the patient also to undergo the surgery. So we should think before we are planning for the alveolar bone grafting that this surgery should not be repeated. So before the alveolar bone grafting, it is very important to prepare the space and room so that the bone will be placed into that space. And that is why expanding the arch is very important prior to the procedure of the alveolar bone grafting. So you can expand as much as you want within the envelope of your soft tissues and as permissible by the fibrous tissue. So this is how you can see the photographs where the expansion was completed by the quad helix. The yellow drop is the PRP, which was derived from the patient's own blood. It was mixed with the bone graft, and this is how the bone grafting was done. And the area was sealed and sutured. So we call it as a watertight grafting, and very useful, because now what is the need of the alveolar bone grafting? That placed graft, the bone will be utilized, the bone will be generated so that the canine will erupt through the bone, utilizing the grafted bone, and thus making the two-piece and the three-piece maxilla as one. And therefore, there is a very crucial time that the alveolar bone grafting should be done. It should always be done when the canine is yet to erupt and the root formation is almost two-thirds completed. That is, it is on the verge of eruption. That is the perfect time when the alveolar bone grafting should be done. Otherwise, what will happen? Canine has to erupt. So wherever the bone will be available, it will erupt in that place. So expand the arch, prepare a room for the alveolar bone grafting, and give a space and direction for the canine so that it will erupt through the bone, utilize the bone of the grafted, it will utilize the grafted bone, and will give a 0% chances of failure of the alveolar bone grafting. So this is the most crucial stage of the mixed dentition phase. I would like to also present a device that was fabricated in the department of SPDC under the guidance of Dr. Puneet Batra, Dr. Kamble sir, Dr. Hazare madam, and Dr. Sunita Srivastava ma'am. So you can see how the RME screw is placed anteroposteriorly, and internal distraction, that is the intraoral distraction device, was fabricated. So where a clear-cut indication of the leafforts are not there, and we have class 3s where anteroposterior uh, push of the anterior can suffice the requirement of the corrections of the class 3. Such appliances play magic. You can also appreciate the space that is available between the premolar and both the premolars on one side, and in between the premolar and molar on the other side. So that is the natural bone that is been we have received it, and now that space can be used for the placement of the implants. So there are no cuts, there are no screws after the screws and platings after the surgical therapy, but a fresh and a new bone available and an implant placed. So this is the magic of the intraoral distractors. The other treatment modality to correct the hypoplastic maxilla is the use of the face masks, the orthopedic corrections, most commonly used for the class 3 corrections in the cleft lip and palate cases before, along with the expansions and before the alveolar bone grafting. So they can be very well used in the growing individuals and very commonly and most commonly preferred appliances to be used for the skeletal class 3 cases in the cleft lip. Then comes the simple orthodontic procedures where we actually have a good work done by the oral surgeons and the plastic surgeons. And really we can see here their work, that how well the aligned arches we had before the orthodontic treatment can be commenced. And now these depends on various factors, right? We cannot always blame the oral surgeons for everything. It might be that the defect only was minimum for this patient, but the cleft defect must have been minimum, or there must be a good growth potential in this patient. She must have her own growth potential. So this was how, but the surgery you can see there is. This is another case who was treated. He had missing lateral incisors and the central incisor was also missing, but only because the arches were coordinated, the upper and the lower arches were coordinated. Therefore, simple orthodontic treatment solved the problem, and the missing teeth were replaced by fixed partial dentures. Later on, the patient also underwent rhinoplasty. So this is how orthodontic. So this was all about the stage 3. Now why did I call this as the longest procedure? Because say from early mixed dentition till the complete permanent dentition is erupted is almost a period of 7 to 8 years. And in that 7 to 8 years we need to do maximum of work so that the orthopedic corrections are being done and we have minimum to do with the orthognathics. If any patient miss out the treatment modalities and the treatment protocols in this stage 3, and if the constriction and the severity of the malocclusion is more, then definitely the stage 4 will be a longer part as compared to that of the part 3. So patient should not be missed in this stage, because there is concept that even parents come to us saying that madam doodh ke daant hain, they are the milk teeth, they will get exfoliated, why we need to save them? As I already have discussed regarding the importance of the deciduous dentitions, it is very important to counsel the parents that even the stage 3 is important, and after the growth has been completed then we will be left with nothing but only the orthognathic surgery. So if one needs to prevent them, this long treatment of 7 to 8 years follow up is really very important, and I really appreciate the efforts of the parents who are still with us in this phase of treatment. It is really very difficult for them to manage to get the patients every 3 to 4 months and sometimes even monthly for almost 7 to 8 long years. So this is what it was in stage 3. So let us now discuss the stage 4, which is the final finishing stage. Now this includes the alignment and leveling procedures of the permanent dentition, either with orthodontics or with the surgical orthodontics. And at the end, what is left is finishing. So orthognathic surgery or orthodontic surgery or orthodontic limitations. So we have limitations because the oral surgeon who is performing the orthognathic surgery has his limitation of working, because he needs to work in an envelope of the soft tissues that has been provided to him because of a lot of fibrous tissue available in the upper face. Upper. So during the development, the affected individual undergoes a series of periodic treatment approaches. We have already been discussing this, affecting the nasomaxillary complex and restricting the growth. So multiple procedures are taken up to normalize the growth and development of the hypoplastic maxilla. Few cases demands a definitive surgical correction in restoring the near normal balance. So there is the indication for the orthognathic surgery. whenever there is a nasal obstruction or the sinus blockages, velopharyngeal dysfunctions, which we called as the VPIs, that is velopharyngeal insufficiencies and the incompetencies, chin dysplasias, wider alveolar defects, and the maxillary hypoplasia. Which the clinical evaluations which is needed is the familial nature of facial clefting, which need to be have a thorough history, a detailed previous treatment history undertaken throughout the period of the development is necessary. Special attention of the psychological history which contributes to the gauge patient's expectation from the orthodontics as well as the orthognathic therapy is needed. A complete extraoral and intraoral assessment with the suitable photographic records with the impression is therefore necessary. Cast evaluation is required for the patients. So if it is a unilateral cleft lip and palate, what we need to follow is the Gosselin yardstick. And for the bilateral cleft lip and palate, we follow the Barrow's yardstick, which gives us the anteroposterior assessment, vertical assessment, and transverse assessment. The surgical indications for the anteroposterior are the leaford osteotomies, modified leaford, distractions, and the mandibular setback. Whereas for the vertical, they are the leaford 1 osteotomy with down fracture, and for the transverse, it is surgically assisted rapid palatal expansion. If the but obvious, it depends on the amount and the quantity quality of the excuse me fibrous. Functional evaluation is very important step and is of the special significance and emphasis to obtain the centric relation with the face bow transfer for every patient undergoing the orthognathic approach. This provides the dual benefits for a total overview of the occlusion of the patient's cranio-mandibular relation, and secondly, it assists in the planning of the surgery because it will help us to know how the splints are being fabricated and how many splints will be needed. So when we come to the airway analysis in the cleft, in adult BCLP, it has a greater reduction in the nasal airway as compared to the UCLP and the cleft palate only. Patients affected by the UCLP and the BCLP has decreased volumes of the oropharyngeal airway as compared with that of the control group. The skeletal class 3 versus the skeletal class, the class 3 is in the normal patient and the class 3 is in the cleft patient. It is very important to understand the basic difference between these two types of the class 3 because normal class 3 mostly has the mandible as a problematic jaw, whereas the cleft class 3 has mostly 99% has the maxilla as the problematic jaw because the cleft maxilla is dysplastic and hypoplastic and most of the time is posteriorly positioned because it is not developed. And the mandible in the cleft patients most of the time whenever we have evaluated it, compared it for some other studies have also, we know that it is most of the time normal and rotated downwards, therefore leading to a mandibular prognathism and a skeletal class 3. So therefore the type and the variation of the cleft plays a major role while planning the surgery. The next step will be the radiographic evaluation to know the tooth number, the level of the alveolar bone, status of the bone graft, impacted missing tooth numbers, anatomy of the condyles, the defect size and extension, and the skeletal discrepancies, followed by the cephalometric analysis. And now what we prefer in the cleft is not just marking the lines and assessing the angles and evaluating the millimetric measurements, but counterpart analysis is the foremost important and the advised cephalometric assessment need to be done for the cleft lip and palate cases. We have our study done on this. A postgraduate student completed this evaluation and we have compared the normal patient's counterpart analysis with that of the cleft, and we have it published also in JEMDS in June 2020 issue. Nowadays, we all believe and are dependent on the digital planning of the softwares, which gives us more accurate measurements, but still old is gold. So one should not forget the manual assessments as well. Before evaluation, the graft evaluation is very important, which is commonly done based with the help of these two scales, that is the Bergland scale and the Chelsea scale. So if there is a failed bone graft, each segment should be evaluated and treated individually, and in such cases, Leaford is used as for the segmental repositioning. Whereas if there is a successful graft, then one can operate the maxilla either with a Leaford or with a distraction osteogenesis as a single integrated unit. Orthopedic surgery with cleft and maxillary advancement has been a conventional standard method for addressing the hypoplastic defects. It is so common, so common. We all know what exactly is Leaford for the constriction of the maxillary palatal mucosa, and also in cases where there is lot amount of the scarring, Leaford has always been proved to be best. But still, it has its limitations. And in such cases where fibrous tissue is much more, because cutting the jaws and replacing it with respect to the cranial base may have a pushback effect if the fibrous tissue is too much. And there comes role of the distraction osteogenesis, where the expansion of the jaw is done millimeter by millimeter by expanding the jaws with a screw. So this is a difference between the distraction osteogenesis and the anterior maxillary distractions as compared to that of the Leafords. So we have a lot of data available in the literature where the comparisons are being done. We have lot of studies done on the patient, the in vivo studies where the efficacy of the distraction osteogenesis, the anterior maxillary distraction along with the Leaford have been comparable, and therefore there are straight cut indications for all these three. This discussion is also very important for a cleft patient, that whether the surgery should be performed first or surgery should be performed later. The primary objective of every modality of the treatment is occlusal stability before and after the surgery. And therefore, the orthodontics play a major role for assessing this. So, alignment of the maxillary and the mandibular arches can actually lead a guidance to us that whether the surgery should be performed earlier or later, because with the orthodontics, the surgical modality of the treatment will be more minor in nature. The surgical requisites is a well aligned arch for the pre-surgical orthodontics, and there we need to establish a good arch form and a stable occlusion table for the post-operative stability. Therefore, whenever there are severely crowded or impacted cases, they should be evaluated and they should be treated based on the requirement. As I earlier also said, that the supernumerary teeth should not be extracted in the first shot, but they should be assessed based on the requirement of the arches. So many of the time the supernumerary teeth help us and are the savers. They save us on the front foot because they replace our missing tooth. Therefore, the need for the expansion is based on the arch structure and the predictive post-surgical occlusion. So it helps us in the arch alignment and to lengthen the arch. So that is the importance of the pre-surgical orthodontics. So here are some of the cases. This is a case one which was treated with Leaford for the distraction osteogenesis. You can see the pre-treatment photographs where we have stage 5 with severe constriction, bilateral cases. Therefore, we are applying the Baru's classification. Skeletal severe class 3 with a vertical growth pattern. Right and left side of the constriction and the anterior bite. So in the phase 1, extractions of the deciduous were done, alignment was done, alveolar bone grafting after the minor expansion was done. Now here, complete correction of the crossbites was not done because that has to be done with the surgery. So the objective of the pre-surgical orthodontics was to achieve the correct inclination of the incisors of the respective jaw bases. And then phase 2 was the distraction osteogenesis of the maxilla with 6 millimeter of the distraction osteogenesis of the maxilla along with 5 millimeter of the setback. So this was a bijaw case. And stage 3 was the finishing and settling of the occlusion. So this is how it was after the post orthodontic alignment, and then the distraction of the maxilla was done. Distractors, various distractors which are available are the alveolar bone distractors, the REDs, commonly used in PGI Chandigarh, maxillary distractors, and what we use are the in the department of SPDC is the indigenous distractor that I have already shown in one of the figure, how it has been fabricated. This is the indigenous distractor that was used for this case. That is the positioning the screw, the RME screw antero-posteriorly. So maximum of the work can be done by this tooth-tooth distractor. The surgical planning was done, and this is how the surgery was carried out. So you can see the improvement in the facial profile where the skeletal class 3 was changed to class 1 with the maxillary distraction and the mandibular setback. Iliac bone graft was used and the PRP was taken for the grafting procedures, and this is how is the final stage of the post treatment, post distraction and post orthodontics. The case 2 where the leafwood distraction was again done. So these are the intraoral photographs with anterior and posterior cross bites and vertical growth pattern with skeletal class 3. So pre-surgical orthodontics with the alignment and expansion was done without correction of the skeletal. So this is what was done after the alignment. So we have good aligned arches upper and the lower. And then before one osteotomy for the distraction was done, we can see the distractor placed in the lower photograph is been placed. This is how a bone distractor was placed. So the initial case was of a tooth distractor. This is a bone distractor where uh, the appliance need to be activated every day for one pitch of a screw to expand the maxilla in anteroposterior direction. There is a major role of the use of single and a double surgical splint. So if it is single jaw, you can use a single splint. For bijaw, you can use double splint. Either it can be used in a maxilla or mandible corrected, but for the double splint, maxilla is the first to reposition, and therefore the second intermediate splint can be placed during the surgery of the mandible, because the mandible is repositioned later after the maxilla is been finalized in its position. Prefabricated occlusal splints are left for almost 5 weeks. Patient is educated about the application of the elastics and encouraged to remove the elastic intermediately so that early range of the mandibular openings can be done, so that training of the mandible for opening can be done to reduce the spasm post-surgical. Orthodontics sees the patients within 24 hours of the splint removal so that sectional arch wise can be placed and the rigidity of the arch and the alignment can be maintained. So this is how the patient was after the post distraction of the maxillary jaw correction. The case 3 where the anterior maxillary distraction osteogenesis was performed. She had multiple teeth missing and a wide cleft was there, and therefore the anterior maxillary distraction was opted for this case because the arches were well aligned. The arches were well aligned in the patient. You can see in the profile photograph was not a class 3 patient, but the defect was too wide for even to go for the alveolar bone grafting, because in such a wide defect the graft will not stay, and therefore the objective in such cases is to reduce the defect and then put a graft. So that will be more stable in an adult patient where we undergo a tertiary bone grafting for the case. So for this case, it was planned that we will do the anterior maxillary osteogenesis. So alignment was done and the maxillary osteogenesis distractor was placed, and this is how the defect was closed. And you can see we had a very little space after the distraction, antermaxillary distraction, and it was followed by the alveolar bone grafting to make the two piece jaws into. After the post orthodontics, patient seems to be very happy, smiling with a wide molar to molar smile after the placement of the process. This is another case where an indigenous distractor was placed. This appliance fabrication and the use was already discussed previously for the expansion. So she again had a mild class 3 with where the crossbite was seen only in the anterior section, whereas the posteriors were aligned and coordinated. So it was planned that only the anterior segment will be distracted in the anteroposterior direction without disturbing the lateral segments. So the RME was again placed anteroposteriorly. We got a good amount of the space, and then two implants were placed in the newly developed alveolar ridge. This gentleman introduced the Leaford-Ware osteotomy followed by the down fracture of and the mobilization. And the key step that he used was the blocks of the cancellous bone from the iliac crest to fill the horizontal and vertical gaps. So here is again another case with a severe hypoplastic maxilla, anteriorly positioned mandible, and who needed the Leaford surgeries because distractions was not a cup of tea for this patient. So alignment, after the orthodontic alignment, the surgical planning was done, splints were prepared, phase bow records were taken. The protocol need to be followed. We cannot miss any step. We cannot miss any step while planning an orthognathic surgery for the cleft lip and palate patient because the surgeon is going to deal with two pieces of the bone for the maxilla to settle it. And therefore, we cannot take risk if they are not aligned because then the stability becomes really a problem. So this is how after the alignment, the surgical procedure was carried out. And you can see the pre and the post-treatment photographs, the alignment that we have received and the anterior positioning of the maxilla along with the Leaford-Ware surgery. Another case of the Leaford osteotomy with severe vertical growth pattern, and just look at the defect of the alveolar defect and deficiency of the tissues. Even a secondary palatal repair will not help this patient because from where we would get the tissues to close this defect, and patient did not agree for a tongue flap. So what we are remained with, we are left with no choice but to go for the Leaford osteotomy because such a deficiency of the tissue, deficiency of the bone, skeletal class 3 and distraction osteogenesis sometimes do not play a role in this case. If you compare this case with the previous one that we discussed with such a big defect, but there was no alveolar cleft defect in that patient, and that is the reason why we could perform anterior maxillary distraction in that case. But here the complete maxilla had to be shifted and positioned anteroposteriorly as with respect to the cranial base. So Leaford was the only option for this and the mandible, and this is how she appeared post surgically. So we have a good facial class 1 profile for this patient after the surgery and post ortho. Another case of the Leaford osteotomy, you can see the depression and the amount of the crowding in the photograph where the expansion had to be done with the NITA expander because NITA expander is the only one which is so flexible that can be fitted into the smaller amount or smaller space available in the maxilla. After the alignment, the arches were prepared with the orthodontic treatment and the alignment, and the patient was handed over to the oral surgeon with but obvious following all the steps, records and everything, and this is how she appeared. I'm sorry, the lower photograph is not visible, but these are the pre and the post treatment comparisons of the post Leaford and the mandibular setback surgeries where we achieved class 1 skeletal profiles of the patient with a good maxilla, a good mandibular correlation with the cranial base, and a skeletal class 1 profiles. Post surgical management, or we can also call it as settling the occlusion, is orthodontic maintenance of the surgical result and detailing of the occlusion are initiated 5 weeks of the initial healing after the surgery. Teeth are ligated for acceptable overbite and overjet with tight intercuspation of the teeth, arch for maintenance and improvement in the dental and the muscular functions. The orthognathic surgery triggers osteoclastic activity and the metabolic changes which may accelerate the post-operative orthodontic tooth movement, and forces should be monitored while giving the forces. The placement of the extended transpalatal appliance is indicated so that it will maintain and retain the corrections being done even after the processes is being given. So I would like to share the photographs of my few of the cases treated with the Cleft team at AVBRH and SPDC under the umbrella of the Smile Trail. So we can see the happy and the satisfied patients. and this is what we call it as miracle. So this was all about the stage 3 and stage 4 of the orthodontic treatment or the treatment management for the cleft lip and palate cases. I would like to pay my tribute to the stalwarts who have worked a lot in the cleft care management with
The combined orthodontic and surgical results your team has achieved by the preNAM procedure, the use of indigenous distractor, and the use of night eye expander are awe-striking and commendable. Your efficient counseling to the caregivers of cleft lip palate patients also cannot be overlooked. I extend my gratitude on behalf of all for the descriptive lecture. Thank you, ma'am. Kindly accept the certificate.
Dr. Megha, have you made me the co-host? Can I share the screen? Yes, am I audible?
Yes, you can share the screen.
Am I audible?
May I now request Dr. Priyanka Niranjane ma'am to take over the next demonstration session on night eye expanders and the selection for the management of cleft lip and palate. Ma'am, please proceed.
Thank you, Ayushi. Can I share my screen? Have you made me the co-host? Okay. And am I audible?
You can share your screen.
Yes. Is my screen visible to you?
Not yet. It is mentioning that you have started screen sharing, but it is not visible yet.
Now?
Yes, night eye expanders. It's visible now.
Yes. And am I audible?
Yes.
Okay. So good afternoon once again. Thank you for giving me this opportunity to share my demonstration on NITA expanders. So just this is a very short video. Actually, whatever is done in the patient, I have tried to cover it not in front of patient, because it's the same procedure what we do in the lab and what we do in the patients. Okay, so just a brief introduction of what is NITI expanders and how we go for the selection of NITI expanders and what are the clinical steps while placement of the NITI expanders. So since morning we have seen the different treatment protocols in the management of cleft lip and palate patient. So arch expansion is almost always an integral part of the general treatment protocol in the management of unilateral cleft lip and palate patients. And why this arch expansion is done? It is mainly done to normalize the facial and dental functions for proper stability of the bone graft, which is subsequently followed after arch expansion. Okay, so arch expansion is almost always done in NITI expanders. That's because the maxillary arch is collapsed and the maxillary dentition is also collapsed. So in order to achieve a proper occlusal relationship between the upper and the lower arch to receive the bone graft and for proper alignment of dentition and facial functions, expansion is done in cleft lip and palate. So one of the most common treatment modality nowadays, which is followed in cleft lip and palate expansion, is that of NITI expanders. Many different expansion appliances are used like quad helix, WL helix, etc. But nowadays, the very nice slow expansion can be achieved with the help of NITI expanders. Sorry. So NITI expanders were first introduced by Dr. W. Arnett in and this NITI expanders, they mainly utilize the property of shape memory and thermal activation of nickel titanium alloy to achieve the desired expansion of the maxilla. Okay, so the philosophy behind the NITI expanders is mainly that the NITI alloy, it exists in two phases. Okay, so one is the martensite phase, which is a parent phase, and the other is the austenite phase, that is the beta phase. So this alloy, it demonstrates thermoelastic martensitic transformation behavior due to cooling or lowering of the temperature of the alloy. So when the alloy is cooled, it gets converted into a martensitic phase, which is a flexible phase where you can manipulate the expander and you can place it in the patient's mouth. And once it is placed in the patient's mouth and when the temperature it rises, it gets converted into austenitic phase. Okay, so the temperature at which this change from one phase to other occurs is known as the transition temperature. So the transition temperature of nickel titanium alloy is 94 degrees Fahrenheit. Okay, so as you can see in this picture, this is a nickel titanium NITI expander. So the design of the expander is, as you can see in the central portion denoted by the letter A, this assembly, the central portion is made exclusively of the nickel titanium alloy with a loop in the center. Uh, Letter C denotes the arms which are made of ortholoi or stainless steel, which can be adjusted according to the dentition, and these two arms are then joined by this adjustable molar boots. Okay, so these are also made of stainless steel, and in this portion it inserts into the lingual sheath, which is welded onto the preform molar bands or the form customized molar bands, and there is a locking indentation is present in the sheath which fastens the appliance through stainless steel lap to the maxillary molar band. In addition, an e-chain or a steel ligature can also be additionally utilized for preventing accidental dislodging of the appliance. Okay, so these these adjustable arms are made up of 032-inch stainless steel, and this is made up of 0.3-inch thermally activated nickel titanium alloy, and this is the stainless steel stainless steel attachment which is inserted into the lingual sheath or the lingual tubes. Okay, so this is the entire design of the nickel titanium NITA expander, and now how to go for it. Okay, so first we have to take the impression of the patient's maxillary as well as the mandibular arch, pour it in the stone or dental stone, or pour it in the dental stone, and then you have to fabricate a band, okay, on the molars. You can use preform bands also, or you can form bands on the molars, and then you have to build a lingual sheath on the molar bands, okay. And then you have to select the appropriate size of the expander, okay. So how to select the appropriate size of the expander? There's one short video where you can see. Okay, so first of all, measure the width between the maxillary, intermolar width between the central pits of the maxillary right and left first molars. Okay, on the patient's cast, maxillary cast. Okay, so this is the patient cast where we have made a band on the maxillary first molar, and we have welded the lingual sheath. So measure the width between the pits of the maxillary right and left first molar. Then measure the width between the mandibular first molars between the tips of the right and left vestibular cusp. So in this mandibular cusp, the distance between the two right and the left mandibular first molars is measured. Now the difference between the two measurements is the amount of expansion which is required. Okay. So first what we have measured in the maxillary cast, that measurement, and then what we have measured in the mandibular cast. Okay. So the difference between the two measurements is the total amount of expansion which is required. Then you have to measure the distance between the right and the left maxillary first molar from the lingual surface where the sheets will be placed. And this measurements, this millimetric measurement has to be added to the amount of expansion which is required. So now the total of all this will indicate the size of the NITA expander to be used. In addition to this, you have to add 1.5 to 2 millimeter to these measurements. Okay. So what is the purpose of adding 1.5 to 2 millimeter is that you want to achieve over correction to compensate for the combined width of band material, cement, and the lingual sheet. That's why 1.5 to 2 millimeter over correction is required to be added to the measurements which we have done. So in this way, the selection of NITA expanders is done. So the NITA expanders are available in various sizes, right from 26 millimeter to 44 millimeter in 2 millimeter increments. And each NITA expander, when it is placed inside the oral cavity, it delivers a force of 350 grams in 3 millimeter increments. Therefore, it is self-limiting. So, what is the clinical technique? So after the appropriate NITA expander is selected based on the measurements, it is it is adapted onto the patient's cast. Okay, so the anterior arms, which are made up of stainless steel, they are adjusted according to the patient's cleft palate patient's dentition. It is proper adapted to each and every tooth. Then the expander is removed, and the central component of the assembly is wrapped with a moist gauze and placed it in the refrigerator. Okay, so this appliance is then placed in the refrigerator. The purpose is to cool it down so that it can become more flexible. Then determine the appropriate band sizes and fit the bands with lingual sheets as usual. Then cement the bands with a dual or light cured cement. Mostly A dual or light pure cement is more preferable because it has greater strength. Then remove the expander from the freezer and then with the gauze still in place, slide the inserts onto the molar sheets and then remove the gauze from the expander. So how does this NITA expander acts? As when this assembly is placed in the oral cavities, the mouth temperature it starts to warm the appliance. As a result of which the nickel titanium wire will start becoming stiff and then it regains its original shape. This property, as we all know, that is the shape memory which is being restored. With the stiffening of the appliance, the expander will begin to exert a low continuous force on the teeth and the mid-palatal suture. And when you dismiss the patient is instructed to sip cold fluids to relieve the pressure as and when required. And the setting when you place the NITA expander, you have to review the patient after 1 week. So normally the expansion is completed in 2 to 4 months, and the appliance is left in place for 2 to 3 months to act as a passive retainer after that. Okay, so this was all about expansion, and so I've told you how to measure the NITA expander on the patient's cast, and once you have measured, you can place it in the refrigerator to make it more flexible, and then the same procedure is applied in the patient's mouth. So the same size of NITA expander is placed inside the patient's mouth.
Thank you.
Any doubts regarding the placement of expander? Anyone?
Thank you so much, ma'am, for sharing your clinical expertise and explaining the topic with such ease.
Thank you so much.
Ma'am, you can stop sharing the screen now. We shall now proceed for a 10-minute break.
I'll like to interrupt. First I would like to present the certificate for this live demonstration. Thank you, Dr. Priyanka,
Thank
for
you, sir.
such a
Thank
wonderful
you.
session. Please accept the certificate of appreciation. Sorry for the long hold.
Meanwhile, any questions that the participants may have regarding the demonstration session or the lectures can be posted in the chat box.
Yes, we got it on the screen now.
Thank you so
thank
much.
you.
Thanks.
Yeah, thank you. So I will not break for any for the time. So we'll directly go to the question answer session. If are there any questions, because I cannot see any question in chat box. This means that all the participants have understood everything or they have not understood anything. So this is the only thing I can think of. If everything has been understood, then only there are no questions. Or if nothing has been understood, there are no questions. So I don't think there are questions, and there are questions coming. So I think we'll take up the questions if they are there. We can you can also post in the WhatsApp group, so we can discuss the questions tomorrow also. So there is a session tomorrow. Day two will be there. So tomorrow during the interactive session also we can take up the questions. So if you are not having questions right now, you can share the questions in the WhatsApp group. So with this, we are ending today's session. Thank you all the participants for joining and patient listening. And we are very much sorry for all the glitches, because this is always a technical thing, and which is not in our hands. So thank you so much.